is to subclassify low back pain, because low back pain has a highest prevalence in the general population worldwide, with 60 to 80% of the population being affected. So it is important for us to subclassify low back pain physiotherapy practice so that we can treat patients efficiently and also to diagnose them well. So in the prevalence, there is a possibility and a higher chance of 24% to 80% of adults to have a recurrence of low back pain. This is according to a study by Cassiano in 2012. The diversity of presentation of this condition is dependent on the etiology, the structure, and even the age, which affects the treatment approaches, so that as physiotherapists, when we are doing our practice, we just don't have to look at back pain as low back pain, but we can look it into different ways. By subclassifying this condition, we can be able to treat the patients well. So our objective was to identify the subclassifications and also to assess the treatments used in our patient physiotherapy department at the Mbagathi Sub-County Hospital. The method that we used to do this study, this was a prospective study with a systematic sampling procedure that was done. Patients' details were placed with code numbers for data security, and the data was stored in passwords and encrypted documents on computer hard drives. And data was captured in Excel and analyzed using SPSS so that we get the records and how the data that we intended to get to be presented. We got an ethical approval from the AMREF Scientific and Review Committee, from the NACOSTI and the Mbagathi Sub-County Hospital. So these were the results. The results of this study was as follows. Most of the sub-classifications of low back pain were based on the traditional duration classification of low back pain, that either classified, most physiotherapists classify low back pain in acute, subacute, and chronic. So the acute classification, the bigger percentage of the data that we collected was 23.5%. and subacute was 39.4%, and the chronic was 37.1%. Physiotherapists also classified low back pain of anatomical origin or classification. This was dependent on the anatomy, maybe the number of the vertebrates, which was 30.2%, and other classifications that were based by nerves, impingement, facet joint, and sacroilium, which was the least with 10%. So that is the distribution of classification based on duration, which you saw that subacute condition was more prevalent. Pathanatomical, that is the graphical illustration, where we put the lumbar intervertebral disc being the highest, muscles that were being classified condition, low back pain was being described as muscle spasm, and nerve impingement and facet and sacroiliac at the end of that type of sub-classification. During the classification, we noted that all the classifications that were done were also based on the ICF domain categories, which pain in the lower limb was 36.1%, mobility in several joints was 24.5%, radiating pain in the segment or region was 20%, generalized pain was 7.6%, and mobility impaired control of complex voluntary movement was 7.1%. And lastly, we had sensitivity to a stimulus, which was 3.9%. So this result showed us a couple of things. It gave us an illustration of how patients were being classified in low back pain. And after that, their treatment that was used, we found out that treatment was varied in different categories, and this is how the treatment results that came out. Exercise combined therapeutic modalities and manual therapy was the highest with 34.4%, followed by therapeutic modalities and manual therapy alone. Combined therapeutic modalities and exercise with 16.9, manual therapy alone was 8.4, manual therapy with exercise was 6.2, then exercise alone was 5.2, and lastly, use of only therapeutic equipment was the lowest, which was 3.4. So in this study, our outcome, what we found out is that irrespective of how physiotherapists classify low back pain, as much as they try to classify low back pain in relation to the duration, which is still a traditional method of classifying low back pain, and also pathanatomical subclassification and the international classification of function, we found out that there was lack of conclusive data on the treatment outcomes as far as they classify the low back pain. The treatment that were used were generally almost the same, with the most common approach of exercise, therapeutic modality, and manual therapy being used. Irrespective of them classifying low back pain in ICF category, we didn't see any data that captured the approach in the ICF category classification by checking on the activity, limitation, and participation restrictions in that area. So we noted that the gap in data recording by physiotherapists was a major thing that we identified, and there was an ability for us to sustain the effectiveness of treatment approaches based on the classifications because there was no data. So it was that in our conclusion, low back pain diagnosis mainly relied only on duration and pathanatomical classifications, and this one shows that there is a gap in managing low back pain as much as it is a common condition, because apart from these three domains of classifying low back pain, there are other domains of stratification and classification models and treatment-based classification models that are used to classify low back pain that were not captured